myself. I'm an epilepsy nurse practitioner here. I worked in neurology all my nursing life, 20 odd years plus, I won't say how long, but specifically in epilepsy since 2012. So, and I do love my job, so which is good. That always helps. So I'm just going to speak a little bit about epilepsy and then specifically post-stroke epilepsy as well. I'm very happy to answer any questions. If I start to ramble, talk too fast, and slow down, because I can do that sometimes, okay? So just in relation to, now let's hang on some current slide. Yeah, that's perfect. To what epilepsy is. So a broad kind of overview of it. So it's a group of conditions characterized by recurrent unprovoked seizures. That's the key, not provoked, because anyone can have a seizure in the right circumstances, okay? And it's thought about 50 million people have worldwide have epilepsy. So it's one of the more common neurological conditions. I think migraine is first, and then stroke, and then epilepsy. And 1 in 20 people can have a single seizure at some point in their life under the right circumstances and never have another again. A study was done in Ireland in 2011, which is very dated now, the only study in Ireland done that looked at the numbers of people with epilepsy in Ireland. And at that time, there's 37,000 people in Ireland over the age of 5, and I think there was it something like 6 or 7,000 under the age of 5 then with epilepsy. I imagine that's grown quite significantly, okay? And often the cause of epilepsy is unknown. So investigations are normal, which can be really frustrating for people. And, you know, they're on medication for seizures, but we don't know why it's happening. But reassuringly, 70% of people with epilepsy are completely seizure-free. They have a good response to medication and live perfectly normal lives. And, you know, there's no issues. And even more reassuring for people with post-stroke epilepsy, that number is 80%, okay? And then epilepsy, it's very different for everybody. And I'm sure you all know that if you speak to peers with epilepsy. There's no, you know, what's the word I'm looking for? It's no one size fits all, essentially. It can be progressive in some people, where it gets worse over time, or it can fluctuate. And what we look for is for it to go into remission, essentially, where the symptoms of epilepsy, the seizures, are not evident, okay? And the rate of epilepsy is rising in people over 65, which is very cruel. You hit your retirement and you start having seizures. But this is because of the aging in the brain and the normal aging. Okay, so as much as our outside body ages, so does the brain inside. So the vessels in that can sometimes change, and that in itself can be enough to cause seizures. And of course, things like lifestyle management, alcohol intake, smoking, all these things can increase that risk even further. Okay. And then in terms of what the definition of epilepsy is, so if we go technical with the International League Against Epilepsy, they have a great website if you ever want to have a look at it. They define epilepsy as, I can't see that up there now, but they define it as, let's see with the, what you call it, let me just go in here. Laura, do you want to read out that end bit, because I don't have it here in front of me, I can't read it out. They define it as a, something.
Up the top, so yes. As a disease of the brain characterized by enduring predisposition to spontaneous seizures.
Thank you. And so essentially what that means is if someone has 2 or more unprovoked, again being the key word, greater than 24 hours apart. So if someone has 2 seizures within 24 hours, that's classified as 1 seizure, okay? And then if someone has 1 seizure with the probability of another seizure occurring being greater than 60%, so that someone has had a stroke or other risk factors for epilepsy, they will be given a diagnosis of focal epilepsy following 1 seizure, because of the abnormality on their brain, the risk of seizure cardiac is much higher. So safety is paramount to make sure you're seizure free. And then in terms of seizures, so there are quite a lot of different definitions. So the top one on top, which I do have in front of me, Laura, is the old one from the ILAE, and I quite like it because it covers all the different aspects of focal epilepsy. So I'm not sure if any of these are relative to anyone listening in. So essentially intermittent stereotypical disturbance of consciousness, emotion, behavior, motor function or sensation which is apparent to the person and on clinical grounds results from abnormal neuronal discharge, so abnormal firing of the brain cells, okay? And, you know, to put that simply, that is abnormal electrical discharges in the brain. But not all seizures are caused by epilepsy, of course, so we always have to be careful when someone presents with a first seizure to make sure we know what the correct cause is. People can have symptomatic seizures. Examples are alcohol withdrawal or, benzodiazepine withdrawal seizures as well, or if someone has a very high temperature, they can have a seizure too. But the goal of seizure management is seizure freedom on one tablet with no side effects. Okay, that's what we're aiming for all the time. And the aim of seizure management really is to stop the seizure, is to be acute seizure management, stop the seizure as soon as possible. And I'll talk a little bit about buccal-midazolam. So that's the go-to first-line treatment for community and hospital-based seizure management. Okay, so then with post-stroke epilepsy, so there's a lot of literature out there with different stats and things. I'm sure you can all have a look and loads will come up. But post-stroke epilepsy is essentially defined as a seizure that occurs after a stroke without any prior history of epilepsy, okay? And it can develop in about 3 to 10% of people who've had a stroke. The highest incidence of stroke occurs for those who've had an ischemic stroke, or you may hear this referred to as an infarct. That's 90% of strokes are caused by this. And that's where there's an occlusion in the vessel where it can happen at the site of the artery, or it can travel to the brain from a different area in the body, and it causes an occlusion, and then there can be ischemic or dead tissue in that area that can cause seizures as well, but obviously that's the area of stroke. And then hemorrhagic stroke is where there's a bleed out, so a vessel bursts or breaks, and then there's a bleed in the brain, okay? And that's less rare. One study did look at 760 patients over 6 years that presented with strokes. And of those, they discovered that 8 to 14% of patients presented with stroke-related epilepsy had the ischemic type of stroke, and 10 to 20% of those had a hemorrhagic stroke. And there is high involvement with the temporal lobe, so I'll highlight the different areas in the brain now. So your temporal lobe are here, as you know, and that tends to be the more prevalent area. And when you've had a stroke, there can be predictive factors or measurement tools that may predict if you are at risk of having a seizure. It's quite technical, even for me, so I haven't broken them down, but you could certainly look them up. So one of them is called CAVE, C-A-V-E, and the other one is SELECT. But essentially what they're looking at are the vascular risks of that person, the size of the area of the stroke, whether there was any cortical involvement, and then the severity of the stroke as well. So all of these are precursors for whether someone will have a stroke or not. But typically, for people with post-stroke epilepsy, we can see it 1 to 2 years after the stroke. And the more time that goes on, the less likely that is to happen, okay? But not in set in stone. And then in terms of classification, so you have 2 types, essentially. So we can have the acute symptomatic post-stroke seizures. Anything going on in the brain, any trauma, anything different to your norm can provoke a seizure, okay? So a seizure that will occur within 7 days of the onset of the stroke will be classified as a symptomatic seizure, okay? Because it's caused due to the acute severity of what's happened. And the risk of a further unprovoked seizure is about 30%, okay? So they may not always be put on medication, or perhaps put in medication for a short time and then it's weaned off, but it's not to say that epilepsy will develop, okay? Where we're more concerned about seizures coming back is someone who's had a remote symptomatic seizure. So that's outside of the 7-day window. And the risk of further seizures then is a bit higher at 60%. So in that incident, most people will be put on a medication in an effort to prevent any further seizures from occurring. All right. How's my speed? Am I okay? Yeah.
Yeah, all good.
Yeah, grand, good. Okay. Sure, this is something, so don't get bogged down by this at all, okay? So this is the classification system for seizures from the International League Against Epilepsy. And it's changed an awful lot over the years. So what you're concerned with is the focal. So focal refers to a seizure that comes from one area of the brain, or maybe 1 or 2 areas. And if you think about it, for simplicity's sake, if you even imagine the tip of your finger and put that to the side of your head, and imagine that where your finger is contacting with your scalp, that's the only area of your brain that's having a seizure. All this is functioning away as normal, you're able to walk and talk, but you just get these feelings come over you. And I'll describe the different focal seizures now in a minute. So they're known as focal aware seizures, and now the new terminology is focal preserved awareness. So don't worry about it, okay? It's too technical. If that seizure activity spreads from where my finger is touching my scalp to involve more of the brain, but not all the way over the brain, then people have seizures where there's an impairment to their conscious level, okay? So it could be very subtle again, staring into space, people call your name, you don't respond, more obvious, where maybe talking gibberish, acting confused, fidgeting, lip smacking, odd behavior, okay, a little bit more obvious to people around you. And when that activity goes from here right across the brain, then there's the tonic-clonic seizure, okay? Some people with a tonic-clonic seizure, that spread is so fast that they don't feel the warnings. They don't feel all the little seizures in between. And then other people may feel it, and they describe that as their aura or their warnings, okay? And I'll very briefly just describe. So the generalized seizures at the end, they're genetic generalized epilepsy. And regardless of what type of seizure they have, their whole brain immediately seizes. So whether it's a little jerk, whether it's an absence, a big seizure, all their brain is seizing. That's the difference, okay, between the two. Focal starts in one area, spread, generalized, the whole brain. And then there's always a subsection that we have no idea what's going on here, okay, and that can get very complicated. And where it's important to know what type of epilepsy someone has, some drugs can be quite niche, and that's what we need to know. But post-stroke epilepsy is focal epilepsy, okay? No ambiguity. And this is our lovely brain. And I'd like to think that the colours are in place when it's, in our heads and fully perfused, but I don't think so. And obviously all the different areas have different functions, and seizures can happen from most of these areas, okay? But more commonly the temporal lobe and the frontal lobe, but also can happen in the parietal lobe, the occipital lobe, not really in the cerebellum. Usually people would have seizures here if they have a tumor down here and they're having seizures from the tumor. Brainstem also wouldn't have seizures originating from there, but they may have seizures travel from the temporal lobe. Brainstem can affect your breathing and your heart rate, so that's quite severe, okay, and very rare, okay. Yeah, so they need to be managed effectively. But essentially, if you're having seizures from these different areas in your brain, you will have different symptoms. So parietal lobe is associated with sensory and feeling. People may get seizures with pins and needles. Occipital is your vision, so they may see things maybe in their seizures. And then temporal frontal can be kind of similar. People may describe deja vu with temporal lobe seizures. Of course, we can all get a deja vu, but it would be more common, more intense, more frequent events. They may get a sudden feeling of impending doom, like something really bad is going to happen, just comes on them for no reason, and with no associated anxiety context, sitting very relaxed, happy out, and this just comes on them really sudden. They may describe a strange taste or strange smell for no reason, or a lot of times they cannot describe the way they feel. They just have these really bizarre feelings that they can't articulate, okay? And we'll talk a little bit more about that in a minute. So this is a slide I have to say from Epilepsy Ireland. I robbed from them. It's more simplified, I think, just in terms of looking at all the different functions in the brain. So obviously, if you have, wherever area stroke is, and it's say in your frontal lobe, then you're probably going to have, difficulty with planning and attention and things like that, okay? And the same with seizures coming from that area. You'd have a temporary, I suppose, maybe difficulty in that task. So for example, temporal lobe seizures are associated a lot with memory. So people with frequent temporal lobe seizures may have difficulty retaining short-term memory. We see that quite a bit. Yeah, so there's techniques and things we can give to people to try and help with that issue. All right. And when it comes to classifying seizures, we always have to be very careful we have the right type of seizure. So some seizures will be epileptic, okay? Other seizures then are what we call non-epileptic. So we'll have some that are caused by other physiological conditions, movement disorders. Fainting episodes can look like seizures. People will convulse and then fall down. Sleep disorders. Someone has low blood sugar. And complicated migraines can also resemble temporal lobe seizures. And then we have non-physiological. So these are psychogenic, they would have been called in the past, but functional seizures. Not a lot of people may be aware of these, but there's a condition called functional neurological disorder. And it means people can have symptoms of a neurological condition, but without having any pathological cause in their brain. Okay, so people may have paraplegia, but there's nothing wrong with their brain. They may have blindness, but there's nothing wrong with their brain. And some people have seizures, but there's nothing wrong with the brain. But it is a condition of the mind, and people will have what looks like a seizure and have no memory of it because there's disassociation associated with it, not blanking out because it's what's happening in their brain. It's the body's response to something. Okay, that's a whole other talk. We won't go there. So getting the right information is really important. And if someone starts to have seizures that are different to your usual type of seizures, please do get a video. That's so helpful, because if we know what type of seizure it is, then we can alter the management to suit that person's needs. All right. So a diagnosis of epilepsy, I think I've always said it's not down to investigations really, because most times they come back normal. It really is based on the clinical account of the event. So how was the person feeling before it happened? What's their recall of it? What's the witness account is the most important. Okay, so what were they seen doing beforehand? What happened during the seizure as well? Investigations can be helpful to a point, but they're not always diagnostic. And video footage is something that we're using a lot now. So if someone's having repetitive seizures, you do add in medication. You monitor the condition over time to see how it responds to the medication. If that's not working, you're constantly reevaluating and looking at the next steps. And then in terms of what causes seizures, so often it's unknown. For some people, as I said, it can be genetic generalized epilepsy, can be born with it. And then there's acquired, and that's what stroke is as well. So stroke is one of the acquired focal epilepsies, okay? And if someone presents with a first seizure and a background of being really well, we need to get CT or an MRI to make sure there's nothing there that needs immediate attention. You know, an emergency situation such as a new stroke, a head trauma, meningitis, or other vascular anomalies, excuse me, or tumours. There can be some other abnormalities on the brain, like a cortical dysplasia, which is really just scarring on the brain that's been there all their life and now decides to throw off seizures. So it's nothing that needs acute management, but at least, you know, we have the cause for it. So new seizures always need to get CT or imaging. And then with investigations, as I said, we don't rely on these too much. And if someone's had a history of a stroke and then they present with their first seizure some months later, we might not always request an EEG, because it will be abnormal when there's an abnormality on your brain. And for most people, it doesn't actually show epilepsy. So epilepsy discharges are very specific on an EEG. And unless you've had a seizure, or it's been around 72 hours around the time you've had a seizure, it's probably not going to show anything, because it's just a half an hour, a snapshot in time. So it's not always helpful. But the video one is very helpful there. Okay, recording on the phone now, which is most important. The imaging and CT, as I said, that's important. If there's any ambiguity around someone's diagnosis, we often do cardiac screening as well, just to make sure that there's nothing else happening. And then we'll order other bloods, look at toxicology screening and septic screening, because obviously high temperature can bring on a seizure. Coming off benzodiazepines or other medications or drugs can bring on seizures as well. It's all about getting the diagnosis right. And this is what we look for. A lot of the diagnosis will go on this. So these are the kind of questions that we ask. So what was the person doing before the seizure happened? Did they have any kind of fainting symptoms? Did they feel lightheaded? Did they stand up suspicion and all of a sudden feel faint or dizzy? Was their heart rate or blood pressure taken? Not always possible, of course. Had they eaten much during that day? Was there any kind of twitching noticed in their body? What was their colour like? All these questions can be important. And then during the seizure, what did their body do? We don't really want to hear if the tonic-clonic seizure or grand mal. What did you see? That's the most important thing. Description is really important. Eyes opened or closed. Were they any level of consciousness during it? They were able to obey commands. What was the level of awareness? Do try and talk to someone. Obviously, if they're in a big convulsion, first aid is priority, okay? But if it's a smaller seizure where they're just kind of zoned out, it's important to interact with them to see their level of consciousness and ask them to do things. Point to the ceiling, point to the door, and do things like that. And timing of the seizure is very important, particularly with convulsive type of seizures. They look like they go on forever. They're very traumatic. I have people tell me that the first one they've seen, the 400th one they've seen is just like the first one they've seen. You know, they never get used to it. And you can see them go on forever. But most of them don't last any longer than a minute and a half or 2 minutes, okay? And was there a post-ictal phase of confusion, headache? Were they drowsy afterwards? How were they at the time that as well? Some people can get a bit agitated. Some people then can develop what's called a Todd's paralysis. So that's a weakness down one side. And we've often had patients, come in on a fast call, which is a stroke intervention, because they have this weakness, and then it turns out that it's actually a seizure they had, and it's not a stroke at all. But if that's new, if you have a seizure and you have a new weakness, you must go to the emergency department, okay? If it's a very typical feature of a number of seizures you've had, then it might not necessarily need to go, but just check that with your team. Okay, and then the types of focal seizures, I've probably said some of this already. So the seizures where you maintain your awareness, okay, people are able to describe to you what's happening. That's the most important thing. They're aware of what's happening in their body. They might have difficulty describing it, but they can feel it happening. And it's a really unusual sensation. And then it can progress into loss of awareness where it might start as above or maybe not. And then it can lead into intermittent loss of awareness, talking gibberish, unable to focus, wander around, maybe even acting like they're drunk. You know, some people think if they've seen people in this type of seizure that they're actually drunk. There's a really good awareness campaign. I think it was the Canada Epilepsy charity. Because when we see seizures on telly, what do we see? The big seizures, okay? So most people don't have any awareness of the little seizures. And they have this a gentleman walking around, but he's shocked, and he's obviously he's shocked and that, and he's walking around a hall, and he's kind of got his face is twisted to one side, and he's making these funny movements and that, and everyone's walking away from him. They're terrified, you know. But then one person who did have some knowledge around epilepsy was able to take him to safety and knew what was happening, you know. So I think we need more awareness around these kind of seizures because it's not always well known. And in terms of managing focal seizures, so stay calm, the most important thing, all right? Stay with the person and reassure them. And remember, their awareness might be altered. So they may respond to you on some level. It could be repetitive words. It might be no, no, no. And if it's something like that, they're maybe not there all the time. They might be in and out of a level of awareness. And it's important that they stay safe. So just guide them away from danger gently. We're not restricting them or holding them down in any way. Stay with them throughout the seizure and time the seizure as well, okay? Most of these seizures aren't treated aggressively. They resolve themselves after 3 or 4 minutes, so maybe a little bit longer. But if there is, because they do have the potential to spread all the way across the brain, as I said, if that does happen, do shout for help. Never be afraid to shout on the top of your lungs, okay? And if you have buccal get someone to get that or get that yourself, okay, and administer it. And with Epilepsy Ireland, their motto, I suppose, is time the seizure, keep them safe, and stay with them, all right? And tonic-clonic seizures are very different, okay, and very scary. So some people may get an aura because it's focal seizures, as I say, start from one area, they feel that happening, but other people, they have no recollection of it. And if they get a warning, they might try and bring themselves, down to a low level where they feel they're safe or call for help or something like that. The tonic then refers to the body becoming rigid, so a person will just stiffen up, their arms may be stiffening here, or they might be fully extended out, and their breathing may become laboured and disrupted. And then the clonic is the jerking movement, okay? But then some people can have just the clonic or just a tonic or, a mixture of things. I suppose the main thing is that they're completely unresponsive. They're gone. They're unconscious during these seizures. They can lose colour. They might have some blueness around their mouth, around their face, which is very serious. They might have spotting at the mouth. The eyes are usually opened and fixed in a fixed stare. Just a violent jerking, very aggressive. When they're coming out of it, you see the body start to slow down, the jerking starts to ease off. Then they may go into what we call the post-ictal or recovery period, where they can be quite drowsy and even unrousable for a few minutes, and it's really deep, guttural kind of snoring sound, a horrible sound, and these seizures. And when they come around, might be very confused, sometimes agitated, and as I said, this weakness that we call paralysis as well can happen. And for most people, they will sleep for quite a while after that. These seizures can be take a lot out of them. All right. And this is our friend. What do we do before buccal midazolam? Before buccal midazolam, they were cephaloid, rectal cephaloid. So you imagine that someone in the community and having their belongings removed, no matter who's around, and having this inserted inside them is just so undignified. So thankfully, we have moved on to this now. And some of you maybe prescribed this. It is licensed for children only, but the adult dose is 10 milligrams. So we get a lot of calls about this isn't the right dose for me because it's the pediatric reference on it. But 10 milligrams, the orange one, is the adult dose, all right? We are looking at licensing it in adults now, and just to save any kind of confusion. If the person is given focally, okay, so in between the inside cheek and the gum, all right, like that. If someone's clenched their teeth, they're not swallowing it, they're in a seizure, they won't be capable of doing that. There's only 2 ml in it. So they won't lose that, even if they're drooling a lot. But if there is a concern that they're drooling too much and you feel it's not going to be absorbed, you can give it nasally. that's not licensed nasally just yet, that is also underway, okay? Half of one nostril, rub it in, half of the other nostril, rub it in. Same here with this, half on one side, and they say inject slowly, but I know in a panic moment, just get it in, okay? And then half on the other side. If a person is lying in such a way that that's not really possible, just get it into the one side, and with the hand on the outside of the cheek, you're rubbing it into the gums like that. Now, we say to give it 5 minutes to take effect, but typically it works fairly quickly within a minute or two. And the goal of that is to stop the seizure. If a person then has had no injuries and they have someone to stay with them during recovery, they don't always necessarily need to go to the emergency department, okay? But again, check that with your own medical team because everyone's case is different. Yeah. And when to give the buccal as well, that's also important. It's tailored per person, all right? There seems to be a generic kind of instruction of 5 milligrams. I think that's too long myself. Again, this is something you have to check with your team. But if someone has a seizure lasting for 2 minutes, why would you wait 5 minutes? That's a long time to be looking at someone convulsing. They're horrible seizures. If someone has flu in around their mouth or anywhere on their body, that's called cyanosis. We tend to say give that straight away. Okay, don't hang about. But I don't want people walking around town with it in their pocket either. You shouldn't be tied to it. And obviously, you can't give it to yourself. So if people tell me they're administering buccal, there's something wrong there. It's given to people who are unconscious and in a seizure. If the seizure has stopped, you don't need it. It has the potential to be abused because it is a benzodiazepine. And that's why there's a limited amount on how much can be given in the home because most people have no problem with one seizure. Some patients I know will even prescribe 2 doses and an exceptional case, sometimes 3. But higher doses of, definitely 2 or more need to be done in a secure environment with oxygen, suction, and medical team around you, so usually just 1 at a time. And then in terms of first aid, so generally you say let the seizure happen, okay? Protect the head so they don't bang against the ground. Clear space around the person, push things away from them, move the danger objects away. We're not pulling someone away from the danger. Loosen any clothing, remove glasses, put them in a recovery position, usually when the seizure has finished. But if you feel there's a risk of aspiration, they're going to swallow their saliva, you can put them underside sooner. Because people are quite rigid, it's very hard to move someone. And if you're kind of trying to move someone in a way, different as opposed to going onto their side, there's a risk that you can injure them as well, if you try to force their arm back or something, you can break a bone essentially, because they're locked in, they're really tight. Stay with the person and reassure them when they come around and time the seizure, as I said. Observe the semiology, record them as possible. I know me sitting here, that's easier said than done. People panic, but it's just to bear that in mind because it's always helpful for the team as well, all right? And I know you're probably reading this and thinking it's all very obvious, but you'd be surprised what my patients tell me. I've had one lady told me she had a seizure in the community and 2 people spat on her. I don't know what they tried to achieve. A person has never swallowed their tongue in the whole of epilepsy, so don't let anyone put their finger or things in there. They lose their fingers and the person may break their teeth. Don't restrain them, as I said, don't move them unless there's risk of danger. And obviously don't give them anything to drink because they might choke on it. So let them come around fully before they do anything like that. All right. And what are the risks of poorly managed seizures? So they can become more difficult to manage over time. So it's really important to link in. I'm hoping you all have nurses in your area because I know clinic appointments can be very difficult to get and they're far and few between. So don't wait until your next clinic appointment to report seizures. They're having seizures, linking with someone, and then we can be treating the seizure constantly and constantly reviewing before you get back to clinic. Yes, also poor quality of life. So if you're having ongoing seizures, that's going to impact on your cognitive functioning. Your memory, as I said earlier, you're just not going to be working at 100%. So your brain has to recover. Every time we have a seizure, your brain has to recover. We see a scratch in our arm, a cut in our arm. We can see that takes 7 to 10 days to heal. And we kind of forget about our brain. We expect it back to bounce back straight away, but it also has to recover. So while it's recovering, you're not going to be functioning as you are, probably. Some people, surprisingly, get back straight away. But if you are having more seizures before your brain has fully recovered from the previous one, you're not going to be cognitively as sharp as what you were. There's no long-term brain damage with seizures, okay? It's just this kind of day-to-day lifestyle that can be difficult. When it comes to brain damage, that's when someone would be in what's written here, status epilepticus. That's a very serious emergency. The old definition was someone in a convulsive seizure for 30 minutes or more, but now we've changed that to 5 minutes so that people can, or emergency services can get in with treatment much quicker. By the time someone gets to 30 minutes of full convulsive seizure activity, at that point, there may be irreversible neuronal impairment, okay, to the brain cells. It's 30 minutes of constant seizure activity, okay? So that's very rare, all right? Most people get in, they get all their medications, they're hooked up to a ventilator, and then that does the breathing for them while we sedate people heavily to stop the seizure activity, all right? So there can be quite serious consequences, I suppose, if people aren't looking after themselves. This isn't an everyday occurrence, and there's things you can do to help, and I'll go through all that now. And obviously the risk of injury as well, you know, when you fall down in a big seizure like that. It's gentler seizures, not so much. These are more really in keeping with convulsive type seizures. And I don't know if anyone here has heard of SUDEP. Anyone here heard of SUDEP? No. So it's not nice to talk about, but it's important to mention, okay? And it's very rare as well. So something called sudden unexplained death in epilepsy. And again, this refers to people who suffer with convulsive seizures, okay? Really those that we get phone calls about, and the numbers are small, thankfully, are young men, early 20s, not taking heed of their diagnosis, not taking medication, out drinking till 8 o'clock in the morning, sleep deprived, probably drugs in their system as well. All these things just aren't going to work if you have a diagnosis of epilepsy, okay? So that tends to be the cause that we get, which thankfully are far and few between. You have more chance of getting knocked down by a car, all right? So please don't worry about this. If you're looking after yourself, this risk is really, really, really low, all right? But I think it's important to mention because it just helps people be compliant with their medications and with their lifestyle management as well. And how can it affect lifestyle? The big one is driving. This probably is the one conversation that I hate the most in my job. Never easy, and I have a slide about that at the end. And then obviously safety, you know, you're in the kitchen, you're working with knives. I did have a patient who was a butcher, and he never had any injuries, thankfully. And you know, walking around with the house with pots and pans and things like that, just use common sense around safety at home. Going out with discos and stuff, the lights, people always worry about the lights. So with focal epilepsy, there does not tend to be any photosensitivity. That is with genetic generalized epilepsy. And again, it's quite rare for that condition. However, if you feel that looking at lights, you know, in the cars and the lights are flickering to the trees and things like that, if you find that uncomfortable and it's not good, just don't look at it, okay? So people tend to learn their own triggers as they, you know, kind of live with their epilepsy. And then in terms of relationships, for women, there's a lot of considerations. Obviously, we want to use medications that is child-friendly if they plan a pregnancy. Some medications interact with contraception as well, so there's a lot more to consider for women. Employment, you'd hope now there's no stigma around seizures. Epilepsy Ireland do go into workplaces and deliver education, which is really helpful. Because I think a lot of time it's the fear of what to do, like what do I do if someone has a seizure in the workplace, there's panic. So if they're prepared and they know what to do, if you're in work and you have a seizure, then you know the stress levels are a lot lower and are much more accommodating. Bookmadarslan can be left in the workplace, and Epilepsy Ireland can go out and do training, and a care plan can be devised so they know what to do if this person has a seizure in the workplace, okay? And with sports and leisures as well, so really contact sports, we try and say avoid, you know, any bangs to the head, concussions can put them at risk of further seizures. Swimming is a little bit like driving. So I suppose if you're able to drive, you should be able to swim. Once you've given the go ahead for that, but do let the lifeguard know and just use precautions like that. Maybe don't go sea swimming on your own, that kind of thing. And obviously it impacts on memory as well, as I've said a few times. So there are, you know, a few things to consider with seizures that aren't well controlled. And why are they difficult to control? So people don't take their medications, okay? So this happens more than you would think, unfortunately. And then the wrong medication. So some medications can be quite niche. So it's always important to know what type of epilepsy a person has. Or they don't have epilepsy. They have one of these other things that I mentioned, you know, a movement disorder or a functional seizure. So the medication's not going to work for these people. And poor lifestyle management, as I said, so out drinking, not taking medications, all these things won't help. Or 30% of people have stroke-resistant epilepsy in the general epilepsy population, which I assume is 20% of people with post-stroke epilepsy, as 80% of people are well controlled with post-stroke epilepsy. Okay, so that's quite reassuring, I hope. And then in terms of treatment options, so anti-seizure medication is the first line of treatment. Don't lose heart if the first drug doesn't work. It can be very trial and error. So the different drugs work in different ways. Some have similar mechanisms of action, and others work very differently. So if the first drug doesn't work, we'll try a second one. So 50% of people, out of that 70% of the general epilepsy population, they have a good seizure response to the first medication they try. A further 20% will need a second drug added in. And there's no way to predict. This is one of the more frustrating parts, I think, about seizures. I would love to say, take this, one of two things is going to happen, I'll see you again, okay? No way to know. You could have 100 people on the same drug, same dose, and all have a very different response. So it's just so individualized, and it's trial and error. There's no way to predict anything, unfortunately. Good lifestyle management is really important. Things we should all be doing, getting adequate sleep, not to overuse alcohol, manage stress well. Stress is a big trigger for people with seizures. I have a slide on triggers here somewhere. Getting adequate sleep, the usual common sense things, exercise, eat well, all that. Ketogenic diet is quite niche and something done quite commonly in pediatrics, because it's not as successful with adults. I think that's because quite a hard diet to stick to as well. It's a high fat, low carb diet. And then if someone has failed a number of drugs, so if they're going through all the medications and not getting a response, we would consider it suitable for surgery. And the first step of that is to go to the monitoring unit in Beaumont Hospital, where you're hooked up to an EEG machine and your brainwave activity is monitored 24/7, okay? And then from that, they may determine that you're not suitable for surgery. So perhaps you might have a couple of different areas in your brain that the seizures are coming from, because what the surgery will do is potentially take away the area of the brain where the seizures are coming from, and then you're seizure free. But if you've more than one area where seizures are coming from, it's not always possible, okay? Surgeries are really good now. They've just come so far with, in terms of safety, just so many different ways of doing these brain surgeries now. And did you watch The Brain Doctor that was on TV? They've done some of the epilepsy surgeries on that. It might be still on the player. It was in Beaumont Hospital. And then kind of end of the line treatment is something called the vagus nerve stimulator. Okay, so that's like a little pacemaker, a battery device that sits under the chest wall, and a little wire goes up along the neck, along the vagus nerve and into the brain. And that has a stimulation that comes on and off throughout the day. For example, on for 20 seconds, off for a minute, on for 20 seconds, off for a minute, all day long. And we do see that can help people. And it also cognitively really brightens people up. Their day-to-day functioning is better as well. Doesn't work for everybody. All these things may work great for some people, but not for everybody. And there's no way to know. There's always options, okay? That's the goal. That's the point here. Always keep trying, always link in. If something's not working, do look at plan B. I remember most people are well controlled. These are all very kind of negative, but most people are really well controlled. So the aim of treatment is that no seizures, no side effects, okay? And that is achievable for a lot of people. Monotherapy, one tablet is appropriate at the time of diagnosis. That's all we need, and we work slowly with that tablet. Adding it in at a low dose, so that might be enough, and then building it up slowly. Because if we go in too quick with a high dose, we may be at risk of bringing on side effects. And we just constantly reassess, okay? So if it's not working at that dose, we'll try another dose. And we will try and tailor it to suit that person's needs. So it's very much a joint decision with the patient and the clinician. They might have preferences. If someone suffers from anxiety, we're not going to add in a tablet that's known to worsen anxiety, for example, so things like that, okay? If someone is starting to go on more than one tablet, or on 2 or 3, but always thinking, can we take away one of the older tablets? So try and take away one of the tablets that we felt didn't really work that great, okay? Because the more medications you're on, the bigger the burden on your brain, the more prone to side effects you are. And it's not even necessarily the last drug that was added in, it's a combination of the drugs, okay? And just always consider alternative treatments as well. And just as I said, with the book midazolam there, trying to get the seizures to stop ASAP. And when we're picking medications, there's a number of things that we need to consider. So the age of onset, whether they're male or female, because of pregnancy and hormones and that. any other comorbidities, the type of epilepsy, type of seizures, interactions with other medications, side effect profile, and just an overall lifestyle, holistic assessment of adding a medication to make sure it suits that person. And triggers. So these are, I suppose, what we call generic triggers, which may affect most people with epilepsy. Stress is a big one. Okay, we see that a lot. So it's about staying on top of it. Everyone has stress, unfortunately. Try and manage it as it pops up. Don't let it build up. Okay, your body's like a pressure cooker. If you keep packing the stress down, it's going to come out somewhere at some point. Lack of sleep is a big one as well. Missed meals, obviously missed tablets. Any kind of sudden shocks or excitement can be a trigger for some people. Alcohol, not when you're drinking. Okay, a couple of drinks is okay. Again, check with your own team about this. But it is a day or two or even 3 days later. So the alcohol gets right on top of the brain, saturates the brain. When it's pulling off the brain, that's when you're at risk of having seizure. So it's never really when you're drinking. And some people as well, if they're going for a drink, or just won't take my tablets in case there's interaction. That's really dangerous. Okay, always take your medication. Have this conversation with your own clinician to see about alcohol and your medication interaction. For some women, menstruation can be a big trigger. So they may have seizures only at the time of their menstrual cycle. That's called catamenial epilepsy, or when they're ovulating. So there can be considerations around that. Menopause as well can be tricky for women. Pyrexia, high temperature in anyone can bring on a seizure. So if you feel you have a high temperature, take something to bring it down and get checked out with your GP, okay? And too much caffeine. So, a couple of cups of tea or coffee is fine, but we don't want volumes of coffee or Coca-Cola. Those monster drinks, Red Bull, they're lethal for the brain and the heart. They should be avoided as much as possible. I did have one lady who drank 2 liters of Coca-Cola a day. She stopped drinking it and her seizures got better. I'm sure her teeth as well. I've got quite a lot of Coke in this, So, and I'll tell you a funny story then. When I worked in Beaumont, we had a lady who had a roundabout near her house. And whenever she went to that roundabout, she used to have seizures. So they were able to hook her up to ambulatory EEG, portable EEG, brought her to this roundabout, captured a seizure. I believe she had epilepsy surgery and then became seizure-free. So it can be quite unique to the individual as well. But that maybe had an association, some trauma with that or something with her, I'm not sure. But yeah, not always straightforward. I'm not going to go through this kind of in great detail, but I suppose on the left you have the lifestyle stuff, as I said, things you should all be doing, and on the right then you have the medications, the considerations around that. So obviously it's much easier to look after yourself. There's no risk of side effects from looking after yourself. There's only good risks. But with the medications, there's complexities around it, risks of, interactions with other meds and all that. So if you look after yourself as much as possible, hopefully you rely less on the medications. Again, not going to go through all these. These are what we have at the moment to manage seizures. Okay, some of these you will never ever be exposed to. All right, the ones highlighted in red are quite old drugs. They're called enzyme inducers. They do have potential to interact with other medications and can be harsh on the body long term. Sodium valproate and furamate are contraindicated in pregnancy, so we would avoid those for women of childbearing age, which is up to 55 years of age. And there's a few niche ones in there, but the rest are available to use as needed. And when it comes to your anti-seizure medication, you can get the long-term illness, which will pay for your medication. Okay, that's normally processed fairly quickly in about 3 weeks, I think. It's important to establish a good relationship with your pharmacy. They're amazing, particularly if you're running low on your meds, they might be able to give you a short supply if they know you well. One of the things that we would advocate for, we did a lot of work around this years ago, is not to change the brand that you're taking. Okay, it's not substitute generics. So, for example, I'm trying to think of different brands. So, levetiracetam is a generic name for Keppra. So Keppra is one brand. We have another brand called levetiracetam. There's another brand called Blue Fish. So if you've been taking the one brand, say Keppra, for years and years, you're seizure-free, and then you suddenly go to, Blue Fish, there is a risk that the components in the other brand are different, like the binding agents, the colorants, and these things may impact on how the drug is absorbed. So even though it's still 500 milligrams of the levetiracetam, which is the active ingredient, the other ingredients can be different, and it can affect the absorption of the medication. So if it's not absorbed as quickly as your old dose, your seizure threshold will lower. Okay, And we've had patients who are seizure-free driving through this and have a breakthrough seizure. It's devastating. So it's just as much as possible. There is a lot of shortages globally, I know, around the medications at the moment. So if it's a case that you just cannot get your brand, that's very different. Do not do without, but as much as possible. Okay. When it comes to blood monitoring then, so as it is with any medication you're taking, you should get your blood checked once a year with your GP. That's things like looking at your liver function, your kidney function, full blood count. We rarely check drug levels anymore because they can be unreliable, okay? So what's important is how the person is doing. If someone is on a drug that can potentially be toxic, and when a drug is toxic to a person, they will be unwell. They'd have a blurred vision, double vision. They might have blurred vision, double vision, ataxia, walking around like they're drunk. They might suddenly get a very bad tremor. These are signs that need to be managed straight away, okay? So in which case we would reduce the medication a little bit and relieve the signs. They're the only reasons we would check levels for toxicity, to make sure someone's taken their tablets as well. And for women then during pregnancy, we would check their levels because the levels can deplete by as much as 50% during pregnancy. So that's a whole other talk as well, but we'll go there just now. And get to know your medication. You know the name of it and know the dose and how often you take it. Not 6 pink buns in the morning and 5 blue in the evening. Okay, that's not helpful. Know your medication and set reminders on your phones and alarms and things. Pill dispensers are very helpful as well to try and help with compliance. If you feel that compliance is a problem, if you're forgetting to take your morning tablet, sometimes we can change medication to once a day. Okay, it's important to monitor that. The main thing is that you need to get your tablets into you. If you forget to take a tablet, there's a kind of a general rule, I suppose. So say you take a tablet at 8 in the morning, 8 at night, and you remember at 12 o'clock or 1 o'clock that you hadn't taken your morning tablets, then take it then when you remember. The general rule is that within 4 hours of when the next one is due, leave the one you forgot about and take the next one a bit earlier, okay? Outside of that 4 hours, take the one you forgot and the next one is scheduled and you're back on track. It's important to get it into you and bring it out with you. Don't just have it in the house, put it in your bag, have it in your person, and then, if you forget, you have it there with you as well, okay? Yes, and be your own best self manager. That's it. It's so important. And things that can hinder compliance, lack of information around the medication, complex drug regimes. You rarely see people on 3 times a day anti-seizure medication now. If that's something you're on, maybe chat to your team. That's quite a commitment, 3 times a day. If people don't believe they've epilepsy or having seizures, they often don't take their medication. And again, that someone can't see themselves in a seizure. So it's that kind of funny condition where if you don't see it, you don't believe it. Fear of side effects, just because it's listed. Of course, there's so many side effects that you may not get them. Remember, the goal of treatment is no side effects, and that is achievable. So we don't want you having side effects either. So if there are side effects on a medication, we can change it. Or sometimes when you start medication and you're building it up, the side effects settle down once you're on the stable dose. Okay, so always have that conversation with your clinician as well. And sometimes people, if they feel the seizures aren't changing, they stop taking the medication. Again, it's very dangerous. You can have a provoked seizure. Link in with your team around that, okay? And obviously difficulties with memories and people with intellectual disability may have difficulty remembering to take their medication. Oh, this is my last slide. I'm flying along. So the driving legislation now, so for someone with a first seizure and no clinic risk, so unfortunately this is not someone with post-stroke epilepsy, they are told not to drive for 6 months, okay? But if you have one seizure and you do have a risk, then that will go to the 1 year mark, all right? Because at that point, you're given a diagnosis of focal epilepsy. With focal aware seizures, where someone does not lose their consciousness or they have no unusual movements, say just a deja vu or a funny smell, they can potentially drive once they have that seizure and no other seizure type for 1 year or more. But it's always the consultant's discretion, so it's up to them to sign you off for driving. And nocturnal seizures in sleep, again, kind of a similar rule. If they have that pattern for 1 year or more, they can potentially drive with ongoing seizures, okay? And that would include seizures where you fall asleep during the day. And there can be some exceptional cases, like seizures on waking up. Some people with genetic epilepsy can have seizures soon waking within the hour. They don't drive at that first hour they wake up, and then they can drive. But again, consultant's discretion. So always the consultant that sign that off. And there's different considerations around tumour patients and those with brain injuries as well. Some can drive, some can't, depending on the type of tumour they have and if they've had any radiation and things like that. That is, final thought, okay? So I can't say this strongly enough. Empower yourself and become the best self-manager that you can be. You know everything about your seizures, and it's up to you to educate other people as well. That's really important. Okay, be consistent with your compliance and good lifestyle management, because it just goes so far. It really does help manage seizure control. Record all your seizures in a diary. You know, how often are they happening? Did you notice any triggers? You know, what did the seizure look like? Was it different to usual? Because I don't know about you, I don't know what I did yesterday. So I mean, coming into clinic then and trying to call what you've had for 6 months is very, very difficult. So keeping that in a diary is really important, and advocate for yourself. Unfortunately, people can slip through the cracks. They might not get things as soon as they'd like. Just sometimes we have to do that. Okay, so that's really important as well. And lean on your family and friends for support. Educate them around the type of seizures that you have and what to do if you have a seizure. That really goes a long way. And there are other most comorbidities that we do see with seizures and epilepsy. So depression and anxiety are common. Okay, so if you feel you're suffering from any of these, please do reach out to your clinician. You can even start with GP. Do not suffer alone. It may get worse, and it can affect every aspect of your life. Okay, and just be kind to yourself. You know, it's a very big diagnosis. You have a diagnosis of stroke, and now they're telling you that you're having seizures as well. Can things get worse? You know, huge psychological adjustment. I may feel like life is stopping in its tracks, you know, but things do get back on place, get back on track again, and just take time with that. Okay, give yourself a bit of time, and it will get easier.